Hello everyone, you're watching sqadia.com. If a patient who is around 30 to 40 years of age happens to be male, comes to you with knee pain, off and on wage knee pain, usually on the one side only, both knees are not involved. It's sometimes only a single knee which gets kind of itchy, achy, and at times it becomes locked as well. Do you think first and foremost synovial chondromatosis would come to your mind? Probably not, but it could still be synovial chondromatosis. What happens is that synovial chondromatosis is a disease which is actually a proliferative disease of the synovium. By name, as you know, it involves the synovial cavity as well as the synovial membrane. Our knee joint is there's a capsule around it, but on the inside there's also a synovial membrane in which contains a synovial cavity and a synovial fluid as well. Now synoviocytes are actually living cells, therefore they can go into some form of a metaplasia and things can be problematic as well. So what happens is there is a proliferation of synovial cells along with the metaplasia of the cartilage. This is associated with cartilage metaplasia. The word has to be remembered in a way that it's not dysplasia or it's not neoplasia. It's actually metaplasia, which actually means that there is proliferation of same type of cells, which actually there is overactivity of the synoviocytes and synovial hypertrophy starts to occur. Along with this results in multiple intra-articular loose bodies. What happens is when the cartilage is overproducing, this leads to aggregation of multiple small cartilaginous nodules, eventually forming a single large nodule or multiple large nodules as well. And when this starts to aggregate, they cannot stick around to synovium because the knee is moving all the time. When the patient gets kind of a locked in, patient tries to actually gets free of this lock and moves and sometimes pushes his or her knee as well. And as a result, when he or she actually pushes his or her knee, this sometimes results in actually dissemination or the loose body which is actually loosely attached to the synovium comes out, and it may mimic synovial chondromatosis, it may mimic loose bodies, it may mimic multiple other diseases as well. Therefore, it's kind of a overlapping sort of a problem where the synovial gets hypertrophy, the cartilage gets metaplastic, and eventually this whole thing separates and comes into the joint. And when it comes into the joint, it is actually again causing the mechanical block, which further impedes the motion and causes increased mechanical symptom of locking and catching in the knee. Along with that, this actually the ranges from synovial tissue to firm nodules of cartilage. What you need to understand is there's a spectrum of disease. It could be simple synovial hypertrophy, in which there may be or no symptom, mild symptoms. Sometimes it may eventually leads to from synovial hypertrophy to mild cartilaginous metaplasia. Then eventually the nodules may be formed. The nodule may be multiple, maybe a single large nodule. It may be adherent to this, and eventually over the period of time it gets detached and goes into the joint as well. When all this is sort of a range, a spectrum of a synovial chondromatosis. Now, when we are talking about synovial chondromatosis, it usually occurs in the age of around 30 to 50 years of age. Male predominantly, it's more common in the male as well compared to the female, about 2 times more common in males as compared to the females. Usually the most common joint involved is actually the knee joint, but it can happen the hip joint as well, it can happen elbow joint as well. Therefore, when we are seeing a patient of synovial chondromatosis, we have to be on the lookout that it may involve some of the other joints like ankle or elbow, which is usually rare, but this can involve these joints as well, or even the shoulder, although that's quite rare. Very rarely you see synovial chondromatosis involving shoulder, but it can. It's called as a monoarticular disorder of unknown etiology. No exact theory is not known that why actually synovial cell starts to proliferate. Eventually cartilage goes into metaplasia, and eventually these nodules form and they may get detached to form of an intraarticular loose body. Although pathogenesis has somewhat been vague, but certain theories have come up, and actually what is known is that probably the inciting factor is could be some form of a trauma, or it could be some form of orthosis, or it could be even the primary problem could be in the Charcot joint as well. Now, the secondary problem which actually arises from the main synovial chondromatosis is intraarticular loose bodies. If there are multiple loose bodies or cartilaginous nodule inside a joint, that joint cannot function properly. And the function of joint is actually to move, flex or extend. Or for example, if you are talking about hip joint, then abduction, adduction, flexion, extension, and circumduction all has to take place. During all these movements, some loose bodies will get trapped into it, and this will not only cause a mechanical blockade to the motion but also lead to problems like pain and symptoms, and patient may not be able to perform his or her activities of daily living. So the main theory which was implicated was that probably the starting event was a trauma, that there was some trauma which happened there. Some part of the cartilage got damaged during this traumatic event. Although there was no fracture, and patient probably overall soft tissue got injured, and patient healed quite rapidly over the time. But as the inciting factor was trauma, this led to the cartilage metaplasia at that very point, which further eventually aggravated into a nodule formation, which may have got separated into, and eventually a large body intraarticularly can be seen. This is kind of a true when you're talking about that if the inciting factor was such that at one point this metaplasia occurred, and if only isolated single large intraarticular body is seen, you can probably say it. But when we are talking about synovial chondromatosis, rarely you have a single large intraarticular body. You have a plethora or multiple large intraarticular bodies which are like spread like beans in the joint. So when you're talking about that, or you're talking about a beads in the joint, then you have to understand that probably the trauma may or may not be the cause. So this is just one theory. Other theories which implicate that probably how this whole process starts is osteoarthrosis, that gradually over the time that as the joints degenerate, as it is around 30 to 50 years of age, some form of a degeneration has taken place, and cartilage goes into a metaplasia, leading to that cascade of whole cycle again. And another theory about it is the Charcot joint, that usually this is seen more commonly in diabetic patients. Why? Because their joints have become neuropathic. They usually do not sense it, and their abnormal mechanical forces which is actually acting on the joint. As a result, due to abnormal mechanical motion and forces, sometimes the cartilage starts to go into a metaplasia, and eventually multiple cartilaginous loose bodies are formed, and eventually they look like beads in the joint, and multiple may be seen. So that is the theory. Although there is no exact known cause or etiology, but these all theories have been implicated. For example, trauma, osteoarthrosis, and neuropathic arthropathy. Now coming to the clinical presentation of synovial chondromatosis. Its clinical presentation also mimics multiple other diseases as well. Therefore, when you are inquiring about the symptoms and signs in the patient, you must be very careful in eliciting the certain signs, as well as you must carefully listen to the symptoms of the patient. As this disease is mainly of a slow progression, usually therefore most symptoms do not appear for quite a very long period of time. And once they appear, the most common symptoms which does appear is usually pain and swelling. And as you know, the knee is usually the most common joint involved. Therefore, knee pain is a a middle-aged male usually comes with the knee pain and swelling may be mild, maybe off and on. They may be associated with effusion as well. Our patient may only have the clicking and catching sound along with the mild pain in the knee joint. Therefore, the presentation of synovial chondromatosis is also sometimes quite vague. So you have to clearly elicit the cause. What exactly is it, synovial chondromatosis, or it is something else? Pain may be worse with activity. Now, this thing also points out that there may be other problems as well. And usually pain, if it's worsening with activity, means this there could be associated with multiple other causes like arthritis, like meniscal injuries and other things as well. Therefore, you have to clearly elicit that, okay, what exactly is causing a problem over there. Is it a young adult who may be having osteochondrous discecans, or is it an active athlete who may be suffering from certain meniscal tear or something like that, or is it purely synovial chondromatosis, which is actually due to locking and catching in the knee joint? The patient is actually having a problem with the mechanical pain in the knee. Other mechanical symptoms which are more sort of a pronounced, because especially they look like a beads in the joint, and when there are multiple loose bodies or cartilaginous bodies present in the joint, they may lead to mechanical symptoms of, especially during the activity like athletic activity, and the most commonly they present with stiffness. Usually these patients come and complain that whenever they are like walking or climbing something, suddenly at certain points the knee gets locked into a position and then they cannot climb stairs properly, or when they're coming down from the stairs, sometimes the knee gets locked and then they're unable to actually come down properly. And by certain maneuvers they may have developed over the period of time, trick maneuvers by which they can actually move out that intra-articular loose body which is getting trapped between the femur tibia, and they move it out, and then they can continue their activities of daily living. Therefore, we have to understand if there is a bursa overlying an osteochondroma, this would lead to increased proliferation, swelling, and effusion may be present as well. And because of the effusion, the knee may be swollen enough that once it goes into a sort of a lock, they cannot actually make it come out, and as a result they may present with sort of a swelling and fixed knee in a certain position, which may be slight flexion or in extension. Physical exam, this could be lead to decreased range of motion, or this could be warmth, erythema, and tenderness over this. What is important over here is that there is no specific sign which may elicit, but when you examine the patient, there are other signs of meniscal injury like McMurray ACL and PCL injuries, like for example pivot shift, reverse pivot shift, Lachman, as well as anterior drawer, posterior drawer. All these tests around the knee may be absolutely negative, which actually not only helps to rule out the other causes, but actually points out towards the synovial chondromatosis may present with no sign at all, and the only things which would be visible on physical examination, or what we can elicit on physical examination, would be simply a decreased range of motion along with the swelling, warmth, erythema, and tenderness. And there is no specific area where it could be tender, because loose bodies may be more common over the superior lateral or superior middle aspect. Therefore, if it's over there, this can be tenderness as well. Sometimes it's the middle side, sometimes the lateral side of the joint which may be tender. Therefore, depending upon where the more mechanical symptoms are occurring and where there is more micro trauma which is occurring due to these mechanical blockade to the motion, that point would be more tender as compared to the other area of the joint.